So it looks like we have a quorum here. We're going to go ahead and get started. So we have Brant, Chris, Tina, Jenna, Lori, and Simi on, and then myself, Brian Cottonsteady, and we also have Patty Marshall, who's my business partner with Make Solutions. Did I miss anybody else who may just be dialed in? All right. Well, thanks for meeting here this morning. Hopefully the 7 a.m. time doesn't conflict with other meetings that you have going on at this time. And we'll probably try and either do 7 or 8 a.m. for the meetings going forward, since it seems like this may work out a little better. Do you have anybody who was not on a previous CNIO roundtable discussion? I thought all the names sounded familiar. Perfect. Well, I just wanted to I think we had really 3 topics that we were looking to discuss today. One was using advanced and LightsOn to pull metrics for projects. The other was the Cerner upgrades and whether you use like a Cerner upgrade center or internal staff to do that. And then the last one I had was IT involvement for hospital downtime operations and how IT is involved with any of the communications and recovery with those steps. I do know that Holly Ellison at Concord was one who wanted to talk about a couple of those items. So I may hold off on those for the time being. Come back to her if she can join here in a couple minutes. Hey Julie, did you just join? We had Julie Mann on. I can't hear you if you are on, Julie. All right. Chris, do you want to kick us off then? And I know you sent in a question about this.
Hi, Brian.
Oh. Hey, Julie. Thanks for joining. You haven't been on one of these roundtables before, have you?
No, I have not.
Awesome. Well, I'll give you just, thanks for joining. I'll give you a quick update on what we do. So these are all either CNIOs or people who work in IT but are involved very primarily or directly with nursing care. And so we get together as Cerner hospitals and just share information with each other, ask questions, make sure that we have an ability or an outlet to go and ask questions and see how other hospitals are doing things. And so it just gives us a chance every couple months to get together, ask those questions, talk about innovations and items that we're doing, and to share best practices. So that's a very open discussion. Cerner's not on these calls, so we can talk about our problems, but also talk about the solutions to make sure that we're doing things and make sure nobody's going crazy with what they're doing.
Great.
And did you just want to do a quick introduction to yourself and Jackson Health?
Yeah, I'm Julie Mann, and I've been at Jackson Health System for over 30 years. I'm a registered nurse. I was the director of patient care for a long time. Went into IT about 6 years ago and created a role for the health system called Clinical Informatic Coordinators. So we had 22 of them throughout our health system. We're a very large, we have 6 hospitals, multiple ambulatory care. We're the primary caregivers for all of Dade County. We're the public health system for them. And we are served by the providers.
Good morning, this is Tina Stamper. I don't hear anybody. Can you guys hear me?
Yes.
Hey, Tina, yeah, I can hear you.
So we've been, so the University of Miami are our primary caregivers for the hospital, and we have other academic affiliations throughout Dade County as well. We have been a Cerner shop since 2008, and we went to Millennium in 2014 when we did a big bang, and we uploaded over 90 some odd applications. So we've We've been on a Cerner journey and trying to make our EHR seamless, but you know, there's a lot of issues, so I'm happy to join your group.
Well, yeah, thank you again for joining. We've got 1, 2, 3, 4, 5, 6, 7 organizations represented today. And I hear you're starting on a Cerner rev cycle journey.
Yes.
So excellent. Well, I'm sure we probably have some sites here that are on Cerner rev cycle, so they could probably give you some insights as well. We were just starting here. Chris was going to talk or ask some questions here about the Cerner upgrades. So Chris, did you want to kick us off?
Sure, Brian. Thank you. This is Chris Skinner, informatics officer for Health. We're, I think, probably as you see on Brian's spreadsheet that they often share, we're a fairly new Cerner customer in that we've been at it just a little over 2 years. We've got 10 facilities and roughly, over 100 practices on Cerner. We are not on revenue cycle. So one of the things that we had done was we had contracted for Upgrade Center as we transitioned most of our analysts from Horizon to Cerner. So they were learning, and we had contracted for the Upgrade Center. Now that we've got a couple under our belt and our contracts coming up for renewal, we wanted to get a feel for, is anybody doing their upgrades on their own? Are they using different consulting firms to work through that? I know part of it is carrying kind of that many staff, long term, kind of maybe in between what you actually need during an upgrade. So yeah, we just wanted to get a feel for kind of what folks were doing, folks that had experience as well, and then really if you do have the Upgrade Center, what's your satisfaction and how much usage or involvement have they had, in your upgrades?
This is Jenna. I'm happy to. We use for our.
Hey, Jenna, I don't know if it's me, but you're fading out.
And we.
Jenna, you're breaking up on it.
Okay, can you hear me now?
Yep, that's perfect.
Yeah, a little bit better.
Okay, I'm having a little bit of network issue this morning, but we did use Cerner for our upgrade last year in collaboration with our clinical applications team. So we did that upgrade together. It was what I would consider a successful upgrade. Now, we really had to stay engaged with Cerner, as they find those critical issues and really pushing them to get those corrected before we went up with the new version. But we did not have any downtime either when we took that upgrade. And I don't oversee this part of it this year, but it's my understanding that we will likely engage with Cerner again this year for our upgrade. But I think as long as it's a good collaboration partnership that you have, ours went really well for our caregivers that we could have impacted significantly. So we did not lose any productivity time. We had no downtime, and we closed our command center early with that upgrade. But there were lots of different reasons for that to happen. But you truly really have to.
Are you remote host? Jenna, this is Brant. Are you remote hosted or you host?
We are remote hosted.
And is this through CernerWorks?
This is through CernerWorks, and we are remote hosted.
So same thing for Jackson, the same issue. We do the same thing as you just said, Jenna, and we had a seamless upgrade, and we're planning a new one. We're having another one towards the latter part of November. Again, it's the scheduling, getting your calendars along with to match yours and being on the Cerner timeframe. That's the big the big stress is trying to get a date, right?
It is. It's getting that date, and once you get that date, we actually got a date, but we're not satisfied with where we were stepping into that date, so we pushed them and moved them back because we committed to not going live until we were really ready to go live. And so again, it's back to that conversation and really engaging with them and ensuring that you have what you need as the client.
Fantastic.
The project management on your healthcare systems end is crucial to the success, and I think that's what you were alluding to. But you really have to get project management around this.
Yeah, this is true. That's pretty similar to our experience. I think the only real issue is we also did an M-page upgrade as part of that, so we saw some latent slowness with the M-page. But we did have a similar experience with the upgrade center. Probably wouldn't be asking this question if the price wasn't so high. I guess it's really what's kind of driving us to continue to reevaluate that.
Yeah, it is an expense, and I know that from a center perspective, we'll do it again. We will likely do it again this year. We're in contracting now, but the goal would be to hopefully not have to continue that for the long term. So really to plan how to be able to have our team really be able to take this piece on from an upgrade standpoint. But I totally understand where you're coming from, because it is quite an expense associated with it.
Chris, I don't remember, were you buying the individual upgrades, or were you doing the Cerner upgrade managed services where you could use them as much as you wanted?
In our original contract, which is kind of what we're still focused off of, or still working off of, we did the kind of the whole kit and caboodle there. So we've got it as much as needed.
The whole all-you-can-eat plan there.
That's right.
Okay. I know Concord Hospital isn't on, but they had previously used the upgrade center. I know they've been really pleased with it as well. They're kind of the same way as you, Chris, in that they're kind of questioning the pricing on it. Been very expensive for them. It's been a positive experience, but it's just been such an expense that they're trying to decide as well whether they want to go and do that internally or continue to use the upgrade center.
Okay.
Anybody else have anything on how they do their upgrades? All right. I've got a couple here from Concord Hospital. I haven't seen Holly on, and she wasn't able to, I didn't see her return my text there. So before I kind of open or go into those, are there other questions that people wanted to talk about? We can go over anything that anybody else has.
Brian,
if you're allowing us to have an open question, I have one, if you don't mind. This is Tina Samper.
Absolutely, Tina, go ahead.
We're focusing on getting our dialysis, all of our dialysis in our documentation from PD, hemo, and CRRT. And Cerner doesn't have the ability to enter negative numbers when patients too much is being pulled off. So I was wondering what other organizations do to handle that. Do they have people go back and forth to document in their output? Because I realize that in the intake and output section, we don't put a negative number in the output, but that's not really how we do our manual flow sheets with when we're doing calculations for it.
Hey, Tina, this is Brand at UT Medical Center. We ended up in iView using calculated DTAs to come up with that negative number, but then only sharing the true answer over to the INO section. And I'll have to, when I get in the office, I could take some screenshots of that.
That would be awesome, because that's what we thought, but our analysts are struggling with trying to figure out how they're making those calculations happen. So that would be great. Thank you so much.
You're welcome.
Hey, and this is Lori at Covenant. Please excuse the road noise. We ended up doing a intake and an output, and I'm speaking mainly for CRT, to where if it was a negative number, I believe it become an intake, and I can shoot you those screenshots. Our nurses did not like the calculation, so they are manually doing that.
That would be great too. Thank you.
Great. Thank you both for giving that information. If you want to.
Oh, sorry. This is Cindy. I was hoping, are you going to share the screenshots for the M page and the iView with everybody, or just directly with Tina? I would also like to see those screenshots, because we're going through the process of trying to get dialysis on EHR as well.
Yeah, I was going to say, if you wanted to send those screenshots or that documentation to me, this is Brian, I can make sure that this gets out to the group, because I'm sure others would like to be able to have that as well.
Sure will, Brian.
All right. Thanks, Lori. Thanks, man.
Brian, this is Jenna.
Hi.
I have a question too in regards to if we're ready to transition. I have a question I'd like to put out to the group if we're finished with that discussion.
Yeah, absolutely. Go ahead.
Okay. We are looking at bringing up the patient safety, the Cerner patient safety dashboards, as well as the Cerner Command Center dashboards. And so we're in the process now of validating the patient safety dashboards. And I'm curious if anyone else in this group has moved forward with them and developed like their standard work around those dashboards, and any issues that they are seeing if they have gone live with them, or any recommendations. Okay, so we may be the first ones on this call to do that. So I'll bring that information back to this group. Because we're looking at it from the patient safety dashboards. They go through all of they align with your falls, with your happies, with your CODIs and your CLABSIs, and then the command center dashboard, obviously for our transfer center, and really aligning with all the like capacity and all those different components within the command center. So once we go live with our first one to go live with is patient safety, but once we go live, the next time we're on the call, I'm happy to give an update if anybody's interested in learning more about those patient safety dashboards.
Yeah, Jen, I think that'd be great if you could bring that back. And also, when we send these notes out, there's a couple other organizations who haven't been able to attend, so they may have something in place as well. So we can certainly see if any of them are working with it. But I have heard of those dashboards myself. I haven't heard of anybody who's running them yet, though. So hopefully you're not too much of on the bleeding edge with either of those.
Yeah. Yeah, it's an interesting process, but we're working through the validation now.
Okay. So when it aligns with the transfer center, is there anything else that needs to be in place for that to work? Do you need any other Cerner modules specifically for that one? I'm thinking like like any bed placement items for that?
Yeah, it's more understanding, ensuring that you've got your iBus upgraded to the level, to the code that it needs to be on. And we're just in the middle of contracting for that command center dashboard, so we don't have all the different components of that. The patient safety, this should really only be like a 12-week project to get up and running, but it's the validation piece and ensuring, if you're close to model, probably not as long. If you've done some customization, then it may take you a little bit longer to get it up. So we don't use the Morse fall scale, we use JFRAT. And so that's caused a little bit of an issue with our data, because the way that, we engage with Cerner, and they built it, but they built it trying to pull the Morris falls, and we don't use that. So it's working through stuff like that with them. That's been a learning journey.
Great. Well, thank you for that. That's good to know as well if other people are on that journey. Any other questions in our open dialogue here? Well, one item that Holly from Concord had out there, and I'm going to put it out there because her and I have talked about this previously and worked on some of this together, is Cerner has the LightsOn and the advanced tools that are available for each of the hospitals to go and look at metrics and see how nurses are doing with particular items that LightsOn pulls. And one of the things that she's been working on there is seeing if they can pull those metrics out of LightsOn or Advance in order to look and see how nurses or different departments are doing, to see if they can use that to drive any process improvement or go into specific areas and do any additional training with staff. And so she wants to know if anybody else is using Advance or LightsOn from kind of a process improvement perspective.
Hi, this is Simi. So I can say that I've gone into LightsOn and Advanced and looked at the data. I've reached out to our team to try to help interpret that data in a more accurate way, because the current presentation of the data is challenging with the time spent per patient, per nurse, because it doesn't take into consideration acuity or other workload related factors. And so while we look at it and we can discreetly say, oh, this nurse spent more time with a patient, until you dig a little bit deeper, it really is a little bit challenging in trying to determine if the time spent is reflective of workload associated with patient care, or is that nurse just, not being as efficient with her documentation processes. So it does, while the data can be useful, it is a little bit challenging right now, the way the data is presented, to really get face up data that's usable until you dig a little bit deeper. That's been my experience.
This is Brent with UT Medical Center. I spend a lot of time with it, not as much time as I think it takes to fully understand this data, but I try to focus. If I focus on a couple areas and then look at the nurses in those areas that have the lowest time in the chart and the ones that have the most time in the chart, then I can send what we call our expert users to spend some time with those nurses to say, how are you doing this fast? Or why is it taking you this long to, and then you can even drill down into the pie chart area down in Advance to look at, okay, you're using flow sheets and we've moved all of this over to the nurse from workflow in page. So you're spending more time trying to find the information. We have to face up, things like that. But we're very early in that development, and I would love for it to be hard coded, and I can push those jobs, and we could coach those nurses real time. But I think it takes a division to do this.
Yeah, this is Jenna. We try to work with it in a similar way. We're not quite as we're not to the point where we're where we send our nurse educators out to work with our clinicians that are taking a little bit longer. We do have the time and chart for nursing and for our providers on our scorecard, but we roll it up in the aggregate. But it's different. It's difficult. I agree. It's difficult to really determine the best way to approach. We have a couple of initiatives that are trying to improve documentation time that we will look in LightsOn to see the impact once we go live with it. For example, moving to the essential clinical data set for our ICU and our med surge areas. And so again, but it's more in that roll up of the number. Sometimes when I go in to review the data, like even some of it doesn't match, like, or it doesn't add up from a number of patients seen perspective, because you'll have the national average of patients seen like 80,000 and we'll be sitting at 80. And, we certainly had more patients than 80 for that week. And so I'm trying to get some clarity around what's happening and where Cerner's pulling that data in to try to figure out why we're having discrepancies like that in our data. But so I think they're still kind of working through the LightsOn, but we do use it, but I think it's at a little bit higher level than what it sounds like some organizations are using it.
Hi.
When I look at the whole, go ahead.
Oh, I was just going to add that to that. So in an aggregate, we were able to use the data. So we did adopt the essential clinical database for the admissions workflow, and we're able to, in aggregate, demonstrate a decrease in time spent in aggregate. But at the unique nurses level, that's where we're probably struggling more. But in aggregate, yes, I agree that you can look in. If when you make a change to have documentation efficiency by optimizing the workflows, that you can in aggregate demonstrate some improvement.
Yeah, this is Chris Covenant. We do use it to evaluate a lot of projects at a high level, kind of as pointer data to point you to maybe something where you'll write a report that's a little bit deeper or, user specific. We use it on a pretty regular basis for some metrics related to our physicians. Our physician liaisons use it to, target certain doctors, for ongoing training. And then we use it pretty heavily for CareWare Connect, to get kind of our monthly usage, and then to target ongoing education there. And then kind of the other thing we do, I think both Lori and I, is we challenge our our Cerner counterpart that anytime we have our monthly meetings with them or whatever, that's usually on the agenda for them to kind of have done that legwork using LightsOn. So that's one thing I would encourage you all to do too, is like really push your Cerner counterpart until it gets a little more formalized, to bring back that LightsOn dashboard, if you will, back to you. And that's kind of what we're doing. So proactively, we're not that, kind of sound like everybody else. We're not that substantiated yet with, checking certain metrics or dashboards in LightsOn on a weekly or monthly basis, outside of the ones I mentioned. But what we do is kind of have our Cerner counterparts do that. And we've had a lot, I think, process improvements kind of come out of that discussion. And thankfully, they're still doing a lot of that legwork.
Our clinical informatics team has, we've divided the hospital by providers and nurses, and they each have assigned units and names of names of staff that they are monitoring. And they send sprints out to each other, and we are able to communicate poor adopters, slow users, and then go coach them one-on-one. The other thing we've identified by looking at reports in advance on LightsOn is seeing that there's some back charting. So we've been able to start to monitor that, where, you know, providers, nurses don't document to the end of the day. So we're working on about 25% of the users are in that category. So we're trying to move the needle with that.
Julie, you mentioned you use sprints when you send out people. I know LightsOn or Advance has the ability to actually do sprints within there. Are you using that functionality or something else?
Yes, that functionality.
Oh, that's great. Okay.
That way there's no paper, no reports, and we are able to move quick with the information.
Okay.
This is Jenna. Would I be able to maybe connect with you to see, to better understand that workflow that you're using with those nurses, with that nursing common chart?
Sure. I have to. I've moved to different role, but we can set something up to talk to one of the supervisors that does that.
Okay, that's awesome. Thank you.
It's not easy, but you'll have to have those people get access to, and have a Cerner account, and then they have to be granted access to the Advance.
Right. That's easy. That's easy to get there, to give it to them. And then, you know, monitor, and then everybody gets put in a different role. Some are managers, others are users. So not everyone can do the same thing.
Julie, could you spend a minute maybe and talk about, I think it's what Simi had started talking about, is the different acuity levels maybe aren't represented from a timing perspective. So it may look like those ICU nurses are very inefficient when it's really they're spending more time with high acuity patients. How are you sort of accounting for that and creating your baseline to know who to go talk to?
Well, you know, it's actually, you develop some intuition. As the more you look at the data, the more you start understanding, and you know the nurse. You know that this is you know, you really have to give it to people who work close with this nurse. And so I guess it's really intuitive, Brian. There's no like metrics for that. It's just, we know the players, and it just doesn't look right. You know, I was looking at all the PAs, I said, and I knew 3/4 of them. And so it was, you know, just looking at where they are and how much time they spend just looking at orders, you know, so it was going to them and then helping them to organize their screens, you know, that they can manipulate and look at things quicker in one page instead of clicking and looking. So I don't know if there's any one report that we could look at, or, you know, we picked a metrics though, Brian. We just picked a number that what's a normal time, and then anything that fell out, we just said we're going to go chase those people.
Sure. Yeah, and I think really the challenge, and it might have been Grant that said it, is you're really just looking at data, and it doesn't really tell the whole story of what's going on there. So you can't really take it at face value until you start digging into it and look at it. So it's a little bit of that intuition and magic that you have to do as well in order to really understand who your staff is, and then figure out who seems to be struggling. But I think it's a good first pass in order to be able to understand where people may be sitting, and then dig into it from there.
This is Brand. As long as you have your nurses in acute care in a nurse position, an acute care nurse position, and then your critical care nurses are in an intensive care nurse position. You can break that down in advance. But I agree. It's a starting point. Like one of my best users, her numbers were through the roof one month when we looked. And I called her and I said, "Okay, what's going on?" She goes, "Oh, I'm precepting. I've been navigating over all kind of charts." She was teaching, so she was her numbers were reflected by that. But then as soon as she was done precepting, her numbers went right back into almost perfect. So it just gives you a starting point.
Having people in the right role is like your first thing. You're correct, because we didn't have critical care nurses in there. So how they work is not like a med-surg nurse. So yes, you're right. That's your first thing, is cleaning up or getting your list, the people in the right positions.
This is Cindy. May I ask, what is your benchmark time spent in the EHR by position? Like, what do you expect? Like, how many minutes are you looking at for a critical care nurse versus a med-surg nurse as if they're above this number of minutes, then I'm worried about them? Or
so this is Jenna. We haven't made it that far. What we've done is we've looked at it from a scorecard perspective in the aggregate. So whether it's an ambulatory, acute, or ED, we roll that number up. So our goal for the healthcare system in the aggregate is 10 minutes, 27 seconds. It's not Cerner's aggregate national average. We do look at that, but we haven't taken it to, we do pull out our critical care and our med surg and see what where it looks like they're spending a majority of their time. And we do the same thing for ambulatory and ED. So when we look at it from that perspective, our acute care nurses have a really robust governance structure and are making a lot of workflow changes through our governance, because it's bedside nurses that make up the governance to really have the opportunity to influence the system. In ambulatory, we don't have as strong of a governance, and also in ED, and we're trying to mirror what that governance looks like on the acute care side. But you can see that our ambulatory and our ED times are well over the national average as Cerner reports them. So we are trying to focus and figure out what is happening in ambulatory and ED to try to drive that aggregate time down. But we don't necessarily have benchmarks for each category separated out yet.
Does anybody use, I don't know if it's still called this, but Citrix Session Recorder to go and look at anybody who may be an outlier? So watch their sessions before you go and connect with them in person.
We use Smart Auditor. Is that what you're?
Smart Auditor. Yeah, I think it's changed into that. I know it's changed names a couple times. Smart Auditor, where you can basically watch somebody's session.
Yeah, this is Chris at Covenant. That's one of our steps their physician liaisons do. Kind of like they look at that pointer data in LightsOn, and then they'll do a smart audit review as well. I think our smart auditor, though, is 7 days, I believe, as far back as we can go before that gets purged.
That's how ours is 7.
Yeah, we use Smart Auditor for, I think we primarily use it for the physicians as well. But honestly, we use Smart Auditor more for safety event reporting and follow-up, and trying to identify where errors in navigation or errors in documentation might have occurred, or missteps related to safety events that are reported. That's typically where we use Smart Auditor primarily, not so much for nursing documentation efficiency, but it's a good idea. Yeah.
Yeah, I just have seen it used before you go out to somebody, and agreed it's probably more on the provider side than on the nursing side. But if you see somebody who's way off on their timings, I have looked at that Smart Auditor to make sure I have a full picture of what it is that they're doing, because I don't want to go after the nurse liaison or the person who's precepting for that week and say, hey, what's going on, as opposed to saying maybe they are struggling and using the old functionality instead of the new functionality.
And this is Lori at Covenant Health. We had a hospital who, it was in the perioperative realm, was trying to decrease time of throughput preoperatively. And we kind of used both tools of looking at, hey, how long is it taking this person versus this person? And again, knowing that this person takes care of ortho versus they take care of someone having a mastectomy. But then we also did some Smart Auditor to see, and found a lot of people doing notes instead of doing other things, which were increasing their time.
So it really sounds like from a LightsOn Advanced perspective, people are using it in different ways and the metrics in order to be able to at least get back out in front of their users. It certainly is a difficult tool to get set up and running to make sure that you're able to use that data correctly. So Julie, thank you for some of your insights. It sounds like you might be more robust than some of the other sites on how you're using it. I'll look as well through some of my materials and things like that I collected on LightsOn in advance over the last couple of years, and I'll see if there's anything worthwhile that I can send out to the group that's sort of how I've seen other sites use it as well, so we can continue to share information around that. The last item I had that was sent to me, but again, this one came from Holly, so I don't know if I want to start this one without her, because I think she may have had some specific questions, but it was really around hospital downtimes and the operations and how you communicate to the staff in the facilities as you get into a downtime and sort of what that looks like, and then how you do recovery. But again, like I said, she had some specific questions, so I may save that for a future meeting when she is able to join. Got about 15 minutes left, so I just wanted to circle back around again, though, and see if anybody had any questions or things they wanted to talk about with the larger group.
So this is Jenna. I would like, I think considering our current state of where we are with the FBI alert in regards to cybersecurity and the threat that we are under in healthcare, that time piece is extremely important. And we have worked last week and this week to really try to ensure that our care side of the house and our ambulatory side understand what the actual downtime procedures are. But what we are identifying is that our ancillary services, we have some opportunity there to ensure that their processes are in place for downtime. And so I am curious, I don't want to, I know that Holly had this question, but I do think with where we are, it is an important topic to kind of understand how other healthcare systems are kind of taking this on, especially under the current threat that we're under. So that.
Hi, it's Cindy. I can, so we certainly are definitely taking proactive precautions with more recently with regards to this concerns related to the cybersecurity. But historically, I can tell you that we have obviously a downtime policy and procedure. We have a business continuity plan that's built into our emergency operations plan for the organization. And, for those, I'm assuming Holly's just kind of question was probably more generally related to what if you had to take an application down and what's your process. Organizationally, we have a team that discusses the timing and the scheduling. We have a notifier that goes out to staff on a weekly basis of all the planned downtimes. Our leadership is informed during the administrator call on Mondays every week to tell so that there's situational awareness about all of the planned downtimes. For unplanned downtimes, obviously we have we mobilize quickly and we're able to put staff right on clinical informatics staff and make them available to the frontline staff to make sure, because I'm sure as most of you experience this as we do at my hospital, is many of our new hires don't know what to do in downtime. Even if you have policies and procedures in place, they actually don't appreciate what paperwork they need or what the workflow is. And so in the last year, what we've been doing is just doing scenarios and just doing tabletop exercises with staff to remind them, this is the paperwork you need, this is where you document this, and this is how you do this. As far as the cybersecurity threat that's occurring right now, obviously at a high level, we're communicating with our staff, we're using the proof point with regard to safe links, and just creating an environment where our staff know what to do as far as external links are concerned and how to determine and or how to report a suspicious email. So those are the things that are happening for the frontline staff, and obviously in the background from an IT perspective is really partnering with the operational teams and making sure that in every area of the organization you have a solid plan on how you're going to make sure you have that readiness. I know one of the challenges we're working on this week or the last week is all of our printing is connected to the network, and how do you move that so that you have a localized printer, so that if we went into a full downtime, how could people get copies of what they need? Or how do you have runners and other people so you can get specimens, labs, etc., or medications to the right places so that they know what the orders are and those types of things. So it's really partnering effectively with your operations team.
Yeah, this is Chris. We have a similar program for downtime. I think one of the things we do well with that is that we have one kind of single policy for planned, one policy for unplanned. Probably the difference is we have a procedure for each area, nursing, ancillary physician. So we've got a little dashboard. When they go to that, if they're nursing, they just click on that one button, and it's very specific to nursing, and kind of the same for the physicians, and so on and so forth. So we keep that kind of up to date by analysts. So, we put that back on our analysts and say, you guys are responsible to make sure these are up to date, through upgrades. And then once a year we do a drill. It's a very, very much like a tabletop, but we load the steps for the drill into our learning management system. They go out and print that, and then some of that are find your 724 device, make sure you can log in, make sure you can pull these 2 reports, and make sure these 2 reports print. Once they've completed that checklist, they'll go complete that kind of task in the LMS. And so I think that helps us keep our folks up to speed, who have been there for a long time. And then it's open to our new hires as well to take that course. So we're actually in the process of doing our end of the year drill now, which was pretty convenient, with everything that was going on in relation to the FBI alerts. And Brian, I've also got some pretty good documentation. I think you may have seen it on some of our downtime stuff. I could hear, with that tabletop drill and some other things. And we do have kind of that. We've got some folks that kind of took that next level. So as far as printers being offline, or printers are local for 724 and some of that stuff, it's accounted for in there as well.
Yeah, I mean, if that's something you'd be willing to share, I'm sure others in the group would like to see that as well.
Yeah, I think we did a presentation maybe at CHC a year or two ago, so we've got some stuff that I think doesn't compromise any of our plans.
Okay.
Yeah, this is Tina Stanford. That would be great because I'm currently working on the same stuff, and I really do appreciate the conversation. Thank you.
So it sounds like everybody has a planned, unplanned downtime procedure, but when I think about an unplanned downtime, you can have multiple types of downtimes. You can have a Cerner outage, you can have a network outage, or you can have really kind of a power outage. Do your plans incorporate all three of those types of downtimes, or is it kind of a one size fits all and you just go and pull the fire alarm on these other items if you need to?
Yeah, this is Chris. Ours does. We try to not be super specific because as soon as you are, it's always something different. But we do have kind of a different procedure for a network out versus maybe a Cerner cloud-based outage. So and that also fits into our communication plan that we have of how we send the message out. Which can also be dependent on the network. So if the network's out, you some ways have to communicate differently as well. So we do have that kind of built in there at a really high level, but it's kind of like Cerner's out. We have STAR for revenue cycle, but really the application versus the network, things like that are kind of built into the plan, and really around the communication, the how you react. Hopefully we've got, like I said, built in, non-network dependency on a lot of our, processes and procedures.
All right, great. Thank you for that. Anything else around downtime that anybody wants to talk about? I know that's a big thing right now with some of the ransomware attacks that have been going on. All right. And thank you for that. And we can always get into that in a little more detail on a future call as well. I know we could go pretty deep on those pieces if we needed to. With the last few minutes that we have, I did just want to talk about the schedule for these roundtable discussions going into 2021, and if there's any specific goals or anything like that people wanted to talk about. So currently we've been doing these every 2 months. So our next one would be in January and then March. Are people still good with continuing on with that schedule? And does this time typically work for people, the 7 to 8 a.m.?
This works for me. Thank you.
Yeah.
Yes.
I know we have pretty good participation today. All right. Maybe I'll send everybody some coffee beans so we can make sure that we can keep getting up at 7.
Yeah, works for us too. And I really like the dashboard as well. That's been a big benefit. When we take it back to the rest of our leadership team, I think it's great that they can kind of see, where everyone's peers are.
That's great. I know Patty has been working to try and keep that up to date. So we'll send out another link to that so people can go and fill that in. But yeah, that really helps people understand where each of the organizations are.
So speaking of which, Brian, I actually, I haven't got very many updates on that. So Brant sent me a complete update. So we should send out the link and ask people to do updates again. Okay.
Yeah, we'll do that. And then the last thing I wanted to mention is on the provider or the CNIO roundtables, every other time we meet, we do what's called an innovation session where a specific organization talks about an initiative that they're doing. So something that's specific to that organization that they set up, either using Cerner tools or something to improve the clinical care. And that's been very well received. So Dr. Callison from University of Tennessee Medical Center did one last time, and he probably went for 45 minutes talking about that and answering questions for other organizations. So I wanted to see if this group would be interested in doing that, not only hearing from other organizations, but presenting on things that you're doing as well in the nursing space. Would anybody like to volunteer to talk at a future meeting and discuss anything you're doing? Well, we can always leave it as an open roundtable at this point, and then in the future, if anybody wants to talk or has any innovations or things that you want to discuss in more detail about what your site is doing or kind of show off, we certainly would like to be able to do that with you as well.
This is Tina Stamper. If I can get some more of our processes, we're in the process of approving a lot of our ambulatory protocols where we're trying to automate specific diagnostic testing and simple diagnostic testing and lab draws. If we're successful in getting one of those implemented through, I'd like to share that and get some input from the group on what they're doing or how, if this is a good thing to move forward. I'll be glad to do that.
Yeah, absolutely. I think that would be great. And I think, Jenna, you were talking earlier about some of the new dashboards you're doing, something like that might be good as well to bring back to the group. So I think we have some ideas, and it certainly is not an hour-long discussion that we're looking for, but if you want to spend 15 minutes, I think those are perfect topics that would benefit everybody. So thank you, Tina.
So I think Jenna actually dropped, even though she's still on, she sent a goodbye. So we'll put it in the notes. That
okay. Volunteered her. Yep.
Yeah, I'm still on. I'm dropping in a few seconds, but I'm happy to do that if we're at a good point with it.
Awesome. Well, I know we're here at 8 and we've got a hard stop for a lot of people. So thank you again, everybody, for joining here this morning. We'll get some notes out and we'll start sharing some of this information that people have volunteered. I really appreciate everybody's time today and participation. Thank you.
Thank you.
Bye.
Thanks, Brian.